Hello and welcome to the EMS On Air podcast. The mission of this podcast is to keep healthcare providers safe, informed, and prepared. Today is March 5, 2021. I'm Jeff Lassers and I'll be your host. This episode was recorded on February 12, 2021. Even though we are located in Southeast Michigan and we mention our home state a lot, today's content applies to EMS on the national and even the global scale. This is a 4-part series focusing on EMS patient care reports, or PCRs. This series has been developed in collaboration with the Oakland County Medical Control Authority, or OCMCA, and various EMS providers as a way of providing information and guidance to EMS agencies and personnel. Although we reference the OCMCA and our local and state EMS protocols, this series is beneficial to all EMS agencies and providers. Like most EMS systems, the Oakland County Med Control focuses on quality assurance and/or quality improvement programs with a patient-centered approach. To facilitate this process, the OCMCA develops and disseminates required education to its EMS providers as one aspect of their annual EMS Quality Improvement Program, or EQIP. Since 2015, EQIP has provided a uniform, standardized, systematic, and responsible quality improvement program through education and OCMCA support. EQIP can be broken down into 3 primary components that all OCMCA EMS agencies are responsible. These include required data reporting, required education, and measurement of protocol knowledge through assessments. In 2021, all OCMCA EMS agencies are responsible for assuring that all of their EMS providers complete this 4-part series or cover the same learning objectives with their personnel. All of the details regarding the 2021 EQIP requirements can be found at ocmca.org/EQIP. EQIP. That's ocmca.org/EQIP. Again, even though this series was developed specifically for EMS providers in Oakland County, Michigan, it certainly applies to EMS on the national and even the global scale. It is impossible to cover every detail, aspect, and nuance of an EMS patient care report. However, we hope that EMS providers and agencies use this podcast series as a way to start a conversation and/or train on producing quality PCRs that consistently show an understanding of current protocol knowledge as well as patient-centered decision-making in the field. Throughout this series, you'll hear from a core group with a vast amount of experience and knowledge. Everyone that appears in this podcast series has significant experience with EMS education, QA/QI programs, as well as EMS agency and system administration. Joining us in today's discussion, we have Bonnie Kincaid, who is the OCMCA Executive Director. We are also lucky enough to have Emily Bergquist here with us, who is the current State of Michigan MCA Coordinator, as well as a longtime paramedic and EMS Instructor Coordinator. We are also joined by Emily Baker, who is currently the EMS Coordinator at Ascension Providence Hospital in Southfield, Michigan, as well as the CQI Supervisor for Alliance Mobile Health, which is a private EMS agency in Oakland County, Michigan. And finally, last but not least, we're joined by my friend John Thoit, a longtime firefighter paramedic and EMS Instructor Coordinator who is the new OCMCA Quality Improvement Coordinator, as well as a shift captain and the EMS Coordinator for the Ferndale Fire Department, located in Oakland County, Michigan. You can find our guests' contact information in the episode description. In this episode, we'll discuss the rules of the game as it pertains to EMS patient care reports. Primarily, our goal is to increase EMS's appreciation and awareness of the laws, administrative rules, protocols, and policies that dictate standards in EMS patient care documentation, as well as how to implement best practices into their work. To accomplish this goal, our guests are going to help us appreciate the hierarchy and role of laws related to EMS documentation, administrative rules, EMS protocols, and agency policies, and how they all work in concert to cultivate quality and consistency amongst EMS patient care documentation. Then, we'll list and describe the applicable protocols related to drafting and submitting EMS patient care records. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Also, check out our website, emsonair.com, for the latest information, podcast episodes, and other details. Follow us on Instagram at EMS On Air. And please, whatever podcast platform you use, subscribe to the podcast and leave us a rating and a review because it really helps us to grow this podcast. I really can't ask you guys this enough. Please leave us a rating and a review and help us get noticed on a much larger scale. Remember, the mission of the EMS On Air podcast is to keep healthcare providers safe, informed, and prepared. So, increasing our ratings and our reviews gets us noticed by more listeners and more sponsors that will lead to increasing our reach, resources, experts, and abilities. Bottom line, ratings and reviews are currency in 2021. It is vital to our growth, and your contribution will give us what we need to serve those that serve our communities. The only cost to you is a few minutes giving us a rating and a review on whatever podcast platform you use. We're available on every podcast platform that you can think of, so it's super quick and easy. Thank you, and enjoy the podcast. We're back today to talk about EMS patient care reports, and today specifically we're going to talk about the rules of the game. And what I mean about that is understanding the role of laws related to EMS documentation, whether they're administrative rules or EMS protocols or even agency policies, and how they all work in concert to really cultivate quality and consistency amongst our documentation through EMS. So, Emily Bergquist, welcome back to the show. Can you kick us off by helping us appreciate the hierarchy of all these things? EMS protocols are a bigger deal sometimes than people really give them credit for.
Yeah, and I can say, honestly, they're a bigger deal than I really realized before I worked in the state office. I was a forgiveness, not permission paramedic, which is maybe not the best way to operate clinically. But just for a quick overview, in our law, which is the Public Health Code, which is Public Act 368 of 1978 as amended, what that law does is establishes our EMS system in Michigan, and it is different than any other state's EMS system because of how our structure is created. So we have state protocols that are approved by the department, which means that since they're coming from the department, which is the Michigan Department of Health and Human Services, that's our current name, they carry the force and weight of law. They are regulatory in nature, and you must abide by them. And I mean, you human, you agency, and also the medical control authorities, we're all bound by those to make sure that our system is functioning appropriately. So when a protocol is drafted, it's not just a person creates a protocol and then you can just kind of like go about your business. We have a committee, the Quality Assurance Task Force, that is actually designated in the statute to advise the department and the Emergency Medical Services Coordination Committee on protocol enactment. And so when a protocol comes to be, there is this group of individuals, mostly physicians, also a pharmacist, a few paramedics, and agency director, that get together and look at clinical standards from all over the country and the world and develop what they can as far as the best clinical and or system protocol that they can. And then once those are enacted, published by the department, your medical control authorities put them through their process, and that's kind of the secondary piece of it. But just so you know, state protocol is not optional. They are not something that you can kind of take or leave. Every protocol that's out there has to be approved by the department, and that's the law.
So in summary, what I heard, protocols hold the rule of law. They're generated from the top at the state of Michigan, disseminated through the medical control authorities. But from what I understand, and Bonnie Kincaid, you're here to kind of answer that, when a medical control authority receives these protocols from the state of Michigan, they have the opportunity to make modifications based on the conditions of that specific geographic area. Can you talk about a little bit how you do that in Oakland County to make sure those modifications are made to serve our patients and agencies?
Sure, Jeff, absolutely. We have a regional protocol system in Southeast Michigan, which includes all 9 MCAs in the entire Southeast Michigan. And anytime there's a treatment protocol that we want to change from the state protocol, we take it through that process. We first identify what issues we have in our area, and then we work with our regional partners to make those changes. We always take it back to our individual MCAs and go through our own protocol process. And everybody has input there. Everybody in Oakland County has input at the Oakland County Medical Control Authority Protocol Subcommittee. And that's where protocol will start to be changed. So that's basically our protocol process. And then it goes up through all the other committees, up to the state, and then up to the QATF.
Thank you. So what I heard there is it goes to a protocol subcommittee as well to help advise the OCMCA's board of directors, its PSRO committee, and all of its various committees to help identify what would be the best articulation of this protocol or this thing that you're trying to create a protocol for, or to change a protocol. Now, John Thoit, you've been a protocols chair for quite a number of years. Why don't you give us a few points on this as well?
As protocol chair, I was co-chair with Gary Proctor before I took the position at the medical control. And as co-chair, we would get protocols in from individuals or other committees that had suggestions in making the protocols better. The protocol committee then would take a look at those protocols with a group of round about 10 providers and anybody else that wanted to come in, and we'd review these protocols for content. And then after they were reviewed, along with the providers that are in the room, there are physicians, so that if it were treatments that we were looking to adjust or somebody suggested might need adjustment, then we would take a look at those and make adjustments. Right now, we are in the process of reviewing all the cardiac arrest protocols. There are currently over 20 protocols that relate to either directly or indirectly to cardiac arrest. The committee, along with a subcommittee that's looking at those specific protocols, are reviewing them for conflicts, any issues, and trying to make the system better and make it easier for the provider to provide care.
Is anybody allowed to just show up at these meetings or be a part of these? Is this a closed meeting? And what role do my EMS providers that I work with have in making suggestions to these?
These are all open meetings. And as far as providers making suggestions, providers can either attend the meetings or they can provide suggestions up through their EMS coordinators to suggest change.
Yeah, I always find that the first step is to talk to whoever liaisons between your agency and the medical control to talk about those. But then I also encourage those people to attend those meetings in whatever way that they can so that they can learn how the system works and become future leaders of our system, because you can't just pick somebody out of the EMS crowd and bring them into a protocol committee. You have to kind of learn how the process goes as much as you have to learn on how the actual call goes for EMS to even come up with a protocol. So if you're an EMS provider in Oakland County, you want to weigh in, you're always welcome to that. This quick commercial break is brought to you by our educational partners, American CME. AmericanCME.com is an online continuing education learning platform designed for EMS providers by EMS providers. Their mission is simple: create and host high-quality video-based EMS CE content with the aim of improving the quality of EMS care while drastically reducing or eliminating the cost associated with EMS training. American CME courses focus on the most current topics and science related to the EMS industry and are available in a format that makes them convenient to access and complete. Over the last year, the EMS On Air podcast has teamed up with American CME to host many of our episodes on AmericanCME.com. This means that EMS providers can earn EMS continuing education credits by completing an entire podcast episode, a brief post-course quiz, and a survey. To do this, visit AmericanCME.com, click on the courses link, then click on free courses. Scroll through the course list and look for the courses with the EMS On Air podcast logo. Currently, there are 22 different EMS On Air podcast episodes hosted by AmericanCME.com, including the episode you're listening to right now, that are approved for continuing education credits for EMS providers in Michigan. But don't worry, we're working on getting our episodes approved in all 50 states and CAPCE accredited. And we'll be releasing another batch of episodes sometime in May 2021. Get on over to AmericanCME.com and get you some credits. Think about it: kicking back and engaged in an EMS On Air podcast episode and earning CEs. Come on, does it get any better than that for EMS continuing ed? Did I mention that you can access all of American CME's content for free? Yeah, free. And now back to the show. Now we're going to talk about some specific protocol, specific to EMS patient care records. OCMCA Procedure Protocol 715, Patient Care Record, Electronic Documentation and EMS Information System. Bonnie. Probably not our sexiest protocol in the menagerie of protocols that we have. Can you give us the intent, purpose, and general process?
Sure. So the whole intent and purpose of these protocols is to make sure your electronic PCR is in and what is in with that PCR. The other part is, how do you get it to the hospital and when do you have to get it to the hospital? Basically, what happens is when you transport a patient, this isn't necessarily the BLS or the first responder that has to get this documentation to the hospital. It is when a patient was transported to a hospital, what do you do? And how do you do it? That's what's covered in these two protocols, 7.15 and the addendum 7.15.1. Really, the biggest thing to take away right now is that when you take your patient to the hospital, besides your verbal report, something has to be left right away. Whether that is your EPCR already uploaded to the hospital and in their hands, or it's a field note or a run sheet with your particulars on that patient. And what's included in that documentation also is dictated by the protocol.
Emily Baker, I hear you work at a hospital.
That's correct.
So you receive these things?
Usually. And hopefully.
Usually. And hopefully per protocol kind of says right here you're supposed to. So as somebody who receives a patient, not just because this piece of paper tells me I have to, I'm guessing there's a reason the piece of paper says it. Give me your perspective from the hospital as the importance of leaving this information behind as outlined in the protocol.
As we discussed in Module 1 pretty heavily, people do read EMS patient care reports. So we need to have that at the hospital so that the nurse that takes over patient care can review it and get further information, so that the physician in the ER can read it, so that the resident that's rounding the next morning after the patient's admitted can use that information as part of their history of present illness. We need to have access to it, and it needs to be complete. Anything that you do or see on scene can have an impact on that patient's hospital course. And while it may seem insignificant to you that you forgot to enter that one detail, it could have significant impact on the decision-making of the physicians going forward. And as far as leaving the street sheet or notes page at a minimum at the hospital before you leave, I always like to bring up the very annoying and stereotypical hit by a bus scenario. People say, well, I gave a verbal report to the nurse, so in 2 hours, so why can't they wait 2 hours for my actual PCR to arrive? Why do I have to do this handwritten sheet? And I always ask them, what would happen if the nurse that took your verbal report walked outside to take a phone call and was hit by a bus?
Yeah, or, had to go to a different patient, or was leaving her shift and giving a report in 5 minutes, or there's a million reasons why that one person you talk to isn't going to be able to carry on the information as well as your complete patient care record is.
Exactly. The documentation is incredibly important. And again, like we discussed, it should stand on its own without the verbal report that was given, without any additional support. That should paint a complete picture of the patient care that you provided. And it also becomes a part of that patient's permanent medical record. It is added to the patient's chart.
So it's added to the patient's chart because it carries specific elements. Now, Emily Baker and Berquist, can you help me with the minimum elements that must be included in our EMS patient care reports per all of our protocols, whether it's the state or Oakland County's protocol? This information needs to be in there. And we're going to cover this more in modules 3 and 4, but we're going to cover this at a macroscopic level right now.
I think the general idea is kind of exactly what Emily just said. That report has to paint the entire picture of the patient. So while there are minimum levels for every single call that you go on, that you had a patient, what you know about the patient, how old was the patient, what's wrong with the patient, etc., there is a varying degree of information that needs to be included, and it is the amount of information that is needed to be able to understand, if you were not there, what actually happened. If you have a patient who's having a STEMI, there had best be a 12 lead included. If you're having a patient who's having a stroke, you had best document when they were last known well. These are things that are super important for the types of patient that you have. So who was there, what's going on with the patient, the description and demographics of the patient, and all of the pertinent things for that patient. And that can mean pertinent negatives as well.
I think it's also very important to note that the patient's history, medications, and allergies need to be included in the PCR. And writing list given to nurse is not including the patient's medication. Yeah, that's not including the patient's medications in your PCR. Because
Why is
if
that a
that
big
list
deal?
is not in their pocket, if that patient goes into the trauma room and is scissor stripped and their belongings are put into a bag, and now I don't have that list readily available, that could be problematic. If it's contaminated or lost, we no longer have that list. And if you just hand it to the nurse on paper, you are not meeting the minimum standard of documentation, of actually documenting the information that you have about your patient.
So it's about making the information readily available immediately, and so it can be enacted upon. If they got to stop what they're doing and then go find the information, it only slows down the process. Depending on what's going on with this patient, time might be brain, time might be heart. John.
If they had the ability to take a picture, if it was an extensive list, and attach it to their PCR, does that satisfy the need of the PCR?
So most of the attachments don't transmit very well.
Very good.
Unless it's a system that the picture attachments, unless you've verified with the hospital that that is something that they can actually receive appropriately, that's a difficult thing, one. And two, for example, and this kind of harkens back to our previous conversation about Nemesis, we do look at patients who are on specific medications, and if it's attached in a list, we can't search by that. I think we'll talk about that a little bit more as we talk about elements and things inside your report, but an attachment is not searchable, but a medication inside the patient's actual record is.
Very good. Before moving on to the next section, let's just do a flyover of the minimum elements that must be included in patient care records in Oakland County, Michigan. Now, a lot of this applies to EMS patient care records on the whole statewide level, and I'm willing to bet that this is a list that's probably pretty valuable to any EMS provider anywhere doing a document report. So, number one, all emergency and non-emergency EMS incidents require submission of a patient care report. Okay, so you have to do one, and there's definitions for everybody of when to do one. In Oakland County, it's pretty much anytime you get called to an incident, there needs to be a PCR generated. So in many situations in Oakland County, we do have agencies that will leave a street sheet or a piece of paper with all the identifying minimum information with the hospital so that they can get to the next call because they're that busy. In those situations, no matter what or what call you go on, the expectation is, even if you left that street sheet, you have 2 hours to have the completed patient care report to the hospital. And every one of those patient care records should include things like the demographic information, who the patient was, where it was, and all that information. Your assessment findings, including your vital signs, patient history, including medications and allergies, not just C-list. And we're going to get into more details of that in later modules. Treatment and interventions need to also be listed into that thing. Medications administered. And if the patient changed in status, no matter what, if you gave a medication or a treatment or an intervention. Then the names and licensure level of each EMS responder on scene. You got to sign the thing. And that includes a signature of the EMS provider who completed the documentation for the encounter. And then there's some time-sensitive emergencies that require specifics, and we'll get into those in later modules. After an EMS provider completes an EMS patient care record like myself, I essentially hit the fax button and my patient care record digitally goes from my iPad into some cloud. I don't know what kind of cloud. And then it shows up at a hospital and it spits out at their fax machine or their printer. And I've seen this happen. But this other thing we talked about in Module 1 was that those records got to make their way to my EMSIS. So can you go over the information found in Protocol 829, Electronic Records and Information System, and kind of give us some guidance on actual patient care submission?
Sure. This is also kind of new, so if I say things that you did not know, do not be sad or surprised. Because we've been trying, before we were in MyEMSIS 3.4, and electronic documentation was still new, the standard was an agency could import their records once a month on or before the 15th of the following month. And as electronic documentation has gotten better and the systems have gotten better, we've been able to kind of walk that time frame back. So agencies now, if it's a PCR that involves invasive procedures, they need to be into MyEMSIS within 24 hours of the incident creation. And agencies that are performing invasive skills have to do their imports at least daily. What that means is if you're a volunteer first response fire department and you're doing medical first response skills, you're not using the expanded scope, you still have kind of a big leeway for the 15th of the following month. But I don't think you have any of those in Oakland County. Your record should be into my MSIS at least daily. There should just be if you're doing batching anymore, and I know those of you are like, what's batching? If you don't know what batching is, it probably means you don't need to know what batching is. But if you're still batching records, it has to be done every day. Most agencies now it's a continuous flow. Each record comes without kind of any prompting. But just for reference, they are getting input into the system and they have to be done daily if you're doing invasive things.
Emily, is there anything the provider that's writing the report has to do to make sure this happens?
Not really. You have to complete your record. So if you're outside of Image Trend, I know that agencies are very, very good at this. They honestly are fantastic. Like I said before, when I used to not be able to go to work or go home from work until after my records were complete, and they really would not let you go home. So they're very good at it. But if you're inside Image Trend, like if you're doing a direct import, you have to complete your record in order for it to move from the draft stage to the final stage. But as long as you're completing your records, signing it, I used to sign last, so I knew it was done. Sign it and sending it, everything should happen. And that should be your agency who's making sure that's happening.
In summary, there is a hierarchy of roles related to EMS documentation and really anything that we do. And those are really disseminated by a state through protocols. And in Michigan, the state disseminates protocols down to the medical control authorities. The medical control authorities make modifications with approval from the state because what happens in Oakland County might be different up in Muskegon or wherever else. Specifically in Oakland County, we have OCMCA procedure protocols 715 and 715-1, which talk about the specifics to patient care records and how they need to be completed and when they need to be completed. And when it comes to the EMS provider, their role is to know when to complete a patient care record, how to complete a patient care record, and know how to submit it so that it is sent directly to the hospital and then into whatever information systems that it gets sent into my MSIS. The agency administration's role is to assure that every time I do that, when I hit submit, it magically goes into my MSIS. The medical control authority's role is to make sure that all the agencies have what they need to ensure that happens. That is all for the show today, everyone. Thank you for listening. Thank you to all of our guests for coming on the show and spreading your knowledge. If you want to get a hold of any of today's guests, you can find their contact information in the episode description. Also, I'd like to take a quick moment to recognize the other EMS providers that were directly involved in the development of the content presented in this episode. Thank you to Allison Bellitti, Luke Bowen, Justin Allen, Yehuda Kranzer, Chris Watts, Matt Prang, and Dan Miller for your time and participation in the development of today's content. Your time is truly appreciated. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Also, check out our website, emsonair.com, for the latest information, podcast episodes, and other details. Follow us on Instagram at EMS On Air. And please, whatever podcast platform you use, subscribe to the podcast and leave us a rating and a review because it really helps us to grow this podcast. Thank you for listening to the EMS On Air podcast. Stay safe and have a great day.